PCI is now an accepted modality for treating left vein lesions, and what has made it possible is mainly the advancement in stent technology in terms of scar thickness, drugs, and polymers, increased operators' experience in using imaging techniques, and stent optimization protocols, and of course, adjunctive drug therapy, of which antiplatelet takes a central role. Can I have this is not moving properly. So, why antiplatelets are important? So as we learned from the ADAPT-DAYS trial that the risk of stent thrombosis increases over time or is maintained over time at least for 24 months, if not beyond, if you have high platelet reactivity. And this is more so if you have acute MI. And this is a trial done on patients with acute coronary syndrome and left vein lesion. So quite expectedly, the COMET registry had showed that you have a lower rate of net adverse clinical events, cardiac death, MI, or stent thrombosis with no excess risk of major bleed if you extend the DAPT beyond 12 months. However, in this trial, only 7% they had two-stent strategy, which underlies that they might not have taken more complex lesions. So again, we have data from another Korean registry where 700 left main bifurcation patients have been treated with two-stent strategy using new generation DAYS, and most of them received a DAPT comprising of clopidogrel and aspirin. And what the trial has shown that if you interrupt DAPT less than 1 year, then there will be a considerable increase in ischemic risk, ischemic events, which will far outweigh the beneficial effect on bleeding events. This is a more recent data from Fuwai registry from China of around 4,000 patients who had no adverse event in the first 12 months after index PCI and was continued on DAPT comprising mainly of clopidogrel and aspirin. And this has shown that definitely continuation of DAPT beyond 12 months, it decreases your ischemic risk without any excess risk of bleeding. And the result is consistent across various subgroups, irrespective of clinical presentation, high bleeding risk status, lesion site, stenting strategy, or stent types. So what happens if we switch over to a triple antiplatelet therapy by adding xylostazol? So again, another trial from China, which has shown that definitely this is a safe strategy as far as bleeding is concerned. However, it won't improve the long-term clinical outcome. So far, so good. But let us remember one thing. Bleeding is a serious event after PCI and is associated with a very real danger of increased mortality, especially if your hemoglobin drops by more than 4 grams. And as you can see from this slide, if you consider patients with high thrombotic risk versus high bleeding risk, on the slide on your left hand, it has shown that if you have a high bleeding risk, the shorter DAPT not only is preferred to decrease the bleeding risk, but also the ischemic risk. So we have several risk protocols to detect the high bleeding risk, like the BARC and the precise DAPT, and also DAPT and PARIS, which assesses both ischemic and bleeding risks. Now, what is interesting, if you have a patient like the left main, patients with left main lesions who have both high thrombotic and high bleeding risk, it is very interesting to note, as shown by Wang in 2020, that the adverse events, major adverse cardiac events in such patients are mainly driven by the high thrombotic risk and not the high bleeding risk. And this is further emphasized by Chiarito in 2021 in his first ever study on left main lesions with high bleeding risk, which has shown that continuation of DAPT, again mainly clopidogrel and aspirin, though it decreases the bleeding risk, the ischemic risk doesn't differ whether you use DAPT or use SAPT. So how you address high thrombotic risk in patients with high bleeding risk? So as the Tourette complex trial has shown, where 15% of the patients had left main PCI, that if you switch over to a SAPT with a potent P2Y12 inhibitor like ticagrelor, after initial 3 months of DAPT, you have an acceptable reduction in thrombotic risk with no excess major bleed. Of course, the shorter depth has been made possible with several advances in stent technology, as I've shown here, in polymers, in drugs, and in stent thickness. Now, what do you do when you face a patient, left main patient, with high bleeding risk? So you have a patient who has both high thrombotic risk and high bleeding risk. And there are certain models that has been developed to assess thrombotic vis-a-vis the bleeding risk. And this is one, the ARC high bleeding risk trade-off model. It is pertinent to remember that both bleeding and thrombotic events, they often have common predictors. And here in this model, you have 8 predictors for thrombotic risk and 8 predictors for bleeding risk. And 4 of them, that is the smoking status, hemoglobin, eGFR, and complexity of procedure, then can predict both. But what is more interesting to note that again, in this trial, it has been shown that even in such patients who have a high bleeding risk, the major adverse cardiac event is mainly driven by the thrombotic risk. And in fact, the mortality from MI or stent thrombosis is 1.9 times higher than that of the bleeding events. The second strategy, of course, will be to de-escalate either to a single antiplatelet agent or to a lower dose of P2Y12 inhibitor, and it may be unguided or guided by doing platelet reactivity or genetic testing for CYP2C19 loss of function. And a meta-analysis of around more than 20,000 patients with such guided APT protocol has shown that there is a definite reduction in MACE as well as minor bleed. So to conclude, left main disease itself is a marker of severe disease, and 1-year mortality is high. It is 14% if you have high bleeding risk and 4% in non-HBR. And DAPT, mostly the clopidogrel aspirin combination, can be continued more than 12 months in low bleeding risk. Those who have both high bleeding risk, we have to remember that both the ischemic and bleeding risk are almost 4 times higher, and you can choose a potent P2Y12 monotherapy. Ticagrelor and prasugrel both have equal bleeding risk, though ESA React 5 has shown that prasugrel might be associated with a lower ischemic risk, and especially in old age and those who are frail, prasugrel may have some advantage. The rates of target vessel vascularization and stent thrombosis, they are independent of bleeding status, which is very important to note, and they are more linked with procedural issues which will necessitate more liberal use of intracoronary imaging and probably radial access. So physician-tailored antiplatelet therapy using several models should be used more frequently, and last but not the least, therapy should be individualized. So we should utilize 5W1H for antiplatelet therapy after left main PCI. We should answer what, who, where, when, why, and how. Thank you.
Thank you very much for concluding in time. Is there any question? Because we are almost completed at the right time. See, would you consider threshold of left main angioplasty low if patient high bleeding risk?
I think, sir, what I have demonstrated in my lecture, when we are considering any left main patient, it will be the main driving factor will be the high thrombotic risk. As we have seen that high bleeding risk itself, if you don't optimize your antiplatelet therapy, the outcome may not be good. Of course, if you go for surgery, that might be an option. Might be.
I think in that case we can conclude this session. I think next session is
One last
also on the
question.
left main.
Yeah, please.
If you want to say the triple drug therapy, which would you advise, and what should be the other two antiplatelets? What should be the doses, and what should be the third drug, and how much would you advise?
I think, sir, that triple antiplatelet therapy.
Not triple antiplatelet,
Then-
triple drug. The third
Triple drug is a
anticoagulant.
oral anticoagulant. I think I won't go for triple anticoagulant. The most practical thing will be combining a P2Y12 inhibitor with a NOAC, and my preference for such P2Y12 in that situation will be clopidogrel, as is made evident by several clinical trials.
Thank you. Thanks.
So one question I want to ask. It's not directly related to left main, but some of my colleagues are using evolocumab in any patient who has severe CAD or severe restenosis, multiple episodes. Any role of that as per guidelines, or what is the role?
Evolocumab.
Yes, sir.
I think because we are discussing on antiplatelets, let me tell you about, and you have raised the question of instant restenosis, right?
Right, sir.
Let me tell you the role of platelet aggregation in instant restenosis is often underemphasized. Instant restenosis is basically a manifestation of inflammation, and platelet aggregation does play a very important role in instant restenosis by not only secreting cytokines of its own, but also stimulating the other mononuclear and neutrophils to come to that area and secrete the cytokines as well, which stimulates a potent local inflammatory reaction leading to an exponential proliferation of vascular smooth muscle cells. So because we are discussing about mainly about the antiplatelet, what I think it is, we should take this opportunity to emphasize when we are looking at instant restenosis, let us not forget about the role of platelets.